Good morning, everybody. Thank you for joining me this morning. My name is Josh Severe. I am a cochlear implant audiologist, and I'm the coordinator of the cochlear implant program at the University of Nebraska in Lincoln, and also the coordinator of the cochlear implant program at Children's Hospital of Omaha. And I'm going to be talking to you a little bit this morning about the use of objective measures in pediatric cochlear implant programming. I have no conflicts to disclose whatsoever. That's our office down here in Lincoln. So our learning objectives for today, overall, just to have a good understanding of the terminology that you need for basic cochlear implant programming. Be familiar with the electrically evoked compound action potentials, or eCAPs, in cochlear implants and understand what role they play in programming itself. And to the flip side of that, also, we're going to talk about electrically evoked stapedial reflex thresholds, or eSRTs, and how they are used and why they are used in cochlear implant programming as well. First thing I want to talk about is just general implant programming. So the majority of the slides that you're going to see today are taken from a cochlear programming software. We at our clinic use all three, but the two patients towards the end of this talk are both cochlear recipients. So I wanted to make sure that the theme kind of flowed as we go through. The different parameters, the most basic things that you will most commonly see in implant programming are your T levels, or your threshold levels, and your upper comfort levels, which in cochlear they're referred to as C levels. So on this little graph here, the T levels are where these green marks are. Your red marks are where your upper comfort levels are. The other couple marks that you see on the screen there, the ones right up here at the top, are where your compliance levels are for your electrodes. You can't go any higher than that without extending your pulse width. And those little blue ticks that you see across there are the threshold markers for eCAPs. Every manufacturer calls their programming terminology something different, even though that all means exactly the same thing. So C levels are your upper comfort levels in cochlear. M levels are what you have for advanced bionics, and MCLs are what you refer to in Med-L. As far as the other ones go that you see listed on there, they're just kind of basic parameters. I don't really have a whole lot of time to go into them in depth, but if you do have any questions about this afterwards, my contact information is up and I'll be more than happy to talk to you about it. So the most common things that people use in cochlear implants, like I said, are your T levels to find out what the softest sound that you can possibly hear may be, and your upper comfort level. What is the loudest, most comfortable loudness level that you can handle listening to at a specific frequency on a day-to-day basis? And for a lot of small clinics, those are really the only two parameters that anybody ever pay attention to. And they're missing out on a lot, and I'll show you why in just a little bit. That you can use some objective measures that you may not have paid much attention to or learned much about going through school that actually will fine tune and make your outcomes for your patients a lot better in the long run. And they also apply to both kids and adults. But today we're focusing on kids. So why do we use objective measures? For kids, they can't tell us how loud things may be. And if they have any other cognitive issues, comorbidities, it may prevent them from judging how loud a signal may be. So it will give us some information pertaining to certain levels of loudness without them actually having to verbally express anything to us about those levels. Also, and the flip side of that with adults with long-term auditory deprivation have a hard time judging what loud actually is. So loudness, the perception of loudness, is a very subjective thing. What may be quiet to you and I may be extremely loud to somebody else. So these measures will help us gauge how loud things should be or need to be in order for someone to achieve their optimal outcomes with their cochlear implant. So we use them a lot to help us guide through difficult situations in programming, like I told you a little bit before, with maybe cognitive issues or just rambunctious kids in general, maybe a little bit more difficult to program. But they also tell us different stories about everybody's own auditory story, because there's no standardized thing that works for every cochlear implant patient. There's variability with everything, and you have to make sure that you take that into account when you're programming each patient. It is a very individualized process. First thing I want to talk about with you is electrode impedance. Then we're going to talk about eCAPs, like I mentioned at the very beginning, and our eSRTs. Those are the three main ones that there are more, but these are you're going to be able to use most clinically in your cochlear implant programming. Starting off with electrode impedance, anytime that we connect our cochlear implant, the first thing we always want to do is make sure what our impedances are, because they can tell us so much. Impedance, it measures the opposition of current flow from the electrode lead in contact to the tissue and the fluid within the cochlea, and it will send a small amount of current into that electrode, and it's not something people can perceive with a auditory signal. They don't hear anything from it when they're testing impedances, but it gives us kind of an idea of what the picture for that electrode is. So by doing this, we can find out if there are short circuits in an electrode. If an electrode's not touching anything at all that may prevent outcomes, we can see these and they will be flagged in our software. That way we can isolate those issues and maybe deactivate an electrode if we need to, in order to correct a problem that may be hindering somebody's auditory performance that may develop and affect their speech in the long run. Let's see. Our impedances are typically the lowest at surgery time. Because we usually have a couple of weeks after surgery time, they typically rise up during the healing process. But once we have that stimulation, usually during their activation day, then those impedances come back down. And over the first couple of months, they end up stabilizing. And as long as there is consistent wear time, then those impedances will stay at a very specific area. If you do go periods of time without using your processor, those impedances may rise, and it may affect also how well you're able to hear. So impedances can also be affected by a lot of different things just in day-to-day life. The first one, like I just mentioned, not using your device at all. If you have higher stimulation rates or you're out of compliance in specific electrodes, that could affect how well your impedances are. So if your impedances rise, then everything may seem a lot quieter to you overall, because the stimulation that we're delivering from your implant has to overcome that change in impedance. Oddly enough, one of the big things that people don't really think about, especially with adolescents, when you start going through puberty, a lot of hormonal changes happening during puberty. I had a patient just last summer come in that their cochlear implant audiologist told them that because they were going through puberty and their hormones were changing, that was causing their impedances to fluctuate and things are getting quieter. And she came to us for a second opinion. And it does seem a little out there for some people, but it is a true statement. Colds, hormonal changes, anything like that can actually affect a lot with your impedances and your overall outcomes. A lot of times this is just a temporary issue and it doesn't hang on very long, but it's definitely something you need to take into account for when you're programming or seeing your patients back during that age span. So this is just a visual of what impedances may shift like. This is the exact same patient. The one where you see activation, that's before we've delivered any stimulation to those electrodes whatsoever. Those impedances, that pattern of them look a little jagged here. They have never received stimulation. And then a week later, that same patient, everything has dropped significantly because now those areas are being stimulated with the cochlear implant across all of the electrodes. So make sure to keep that in mind when you're setting your levels as well. And no matter what, always check your impedances at every single visit. One of the first ones that I want to talk to you about are eCAPs. I've noticed over the past few years, eCAPs are not used in a lot of clinics, especially smaller clinics. and they can tell you so much information about neural survival, what a patient can hear. So, and it's embedded in the software. It takes not a lot of time to do, and the patient doesn't have to tell you anything in return. This is a great measure that you can perform to give you some more input on how you want to go about doing some programming. eCAP itself is just a recorded response from stimulation across a very specific population of neurons. So around the areas of each one of the electrodes, we will check that impedance or those eCAPs just to see how well that nerve is responding. What is very important to remember about this, we can determine some integrity with the nerve, how well the nerve is doing. Uh, if we find a threshold of specific electrode for an eCAP, that means we know that patient is hearing something at that level. But it's important to remember that it is not a measure that tells you this is the softest sounds they hear, so you can't use that as a threshold, and you can't use it as an upper comfort level. We just know that that level is audible to that patient. We just don't know how loud or how quiet that is. So bearing that in mind, there is no one-to-one relationship when it comes to a behavioral threshold in any way. So what a great rule of thumb is when you go to use your eCAP thresholds, once you start programming and you have your threshold levels and your upper comfort levels, your eCAPs should fall somewhere between your threshold and upper comforts somewhere. So we know it's louder than it is for our thresholds, and we know it necessarily isn't the loudest part to be the most comfortable loudness level either. It should fall somewhere in between. It could be closer to the upper comforts, it could be closer to the threshold, but it most likely is going to be somewhere in between those two measures. It's a great starting point for pediatric programming. It may give you a good pattern per se of how the map might look in the end, but you should never ever use it to set your thresholds or your upper comfort levels on each electrode by using your eCAPs. It is just a starting point to give you more information of what that child may be hearing. We know they hear something at that level. We just don't know how loud that actually is at that point. And as regard to eSRTs, there's a strong correlation between the upper comfort level, so our top measure that we're looking for behaviorally, and the threshold for an eSRT. It's a great tool to use for kids if they can't tell you how loud things are. It requires a normal temp, so make sure you have a good type A temp, and you can go through and use a probe tone frequency of 1,000 hertz and stimulate it on decay, and you're looking for a threshold that's kind of like an acoustic reflex. It may look a little different on the screen, but you're still looking to it to the same level. So we're trying to find where 0.02 is, and I'll show you a visual of what that looks like in just a minute. And that usually correlates where the upper comfort levels of our map should be. The problem in kids we have oftentimes with these is kids have a lot of middle ear issues. There's a lot of otitis media, a lot of fluid going on. So that may, tubes, those all may hinder us getting eSRTs. So bear that in mind. You have to have a normal temp in order to get this. So when you run these on a decay, this is done with a 226 hertz probe tone. If you do that, they typically come in under where the upper comfort levels are. A paper a couple years back that was done by Jace Wolf found a stronger correlation with upper comfort levels with 1,000 hertz probe tone. So make sure that you're using that whenever you go to run these, but this is typically what the measure will look like. So if you present 3 beeps in an electrode, these pictures here, 1, 2, 3, and it will stop, play 1, 2, 3 again. And that's what we use as our actual measure in order to establish where those upper comfort levels are. And I know you're thinking right now, wow, you've been lecturing at me forever. How can I actually use this in clinic? Well, I'm going to give you a couple of case studies to show. Both of these were second opinion cases that were sent to our clinic. The first I'm going to show you is implant user. She was 17 years old and had used her implant for 4 years. She had sound awareness, so she could tell where sound was coming from, had no idea anything that anyone was saying to her. She had done horribly in school for the past several years, was using a caption call phone, and she had to communicate with everybody by pen or paper. So when she first come in on her initial visit with us, this is what her map looked like. And the thresholds have a very interesting shape to it, but without any other further testing or anything, we really can't make any judgments based off of this. This may be where she is. So one of the first things we did was to run her eCAP thresholds. So I want you to look at where the C levels are here. So these levels right here. So we see this one starts at 150 here, and we're going across, but this one starts at 150. So we run eCAP levels and found out that she should be hearing significantly above this. So she had 0% word recognition when we started this. This is what her map looked like immediately after testing and reprogramming. So you've noticed already, not only have our thresholds gone up significantly, her eCAP marks are in here now, but just off the first electrode alone, we have gone up 29 units just on that first electrode, but all of them are significantly higher. She did have some issues with some misophonia, so that's why these electrodes were turned off, but they were reallocated elsewhere. So over the course of a 6-month span, this 17-year-old went from 0% word recognition to 85% word recognition. And this was done with a combination of both using our eCAP thresholds that we talked about, and we set our upper comfort levels by using our eSRT measures that we discussed. So this was just something you can do in the office. I don't know why they're not done more, but her grades have significantly improved. She went from being put in the special ed classroom to now she has straight A's in her mainstream classroom. She did not use ASL in any way, so we couldn't use an interpreter with her. So she was just struggling overall. I'm really happy with her progress and how she's doing now. The last one that I want to talk about is a 6-year-old male, was also a transfer patient to us. He born full term, failed his newborn hearing screening. When he followed up, he was diagnosed with bilateral or binaurally profound hearing loss by an ABR. They implanted him at 1, did really, really well. Age 5 or 6, people started noticing something was wrong. The mother of this child took him to 4 different centers in 4 different states to have him evaluated to see what was going on with his cochlear implant. And the last one that they had went to made a lot of changes, but mom noticed that things were getting a lot worse. She reported to us that his speech had gotten a lot mushier, and he had become a really good reporter of his own situation. So he started telling her that it sounds like it's raining in my head, only in his left ear. That was important. A local CI support group sent them over to us for a second opinion. I felt bad. This guy, little guy, is amazing. It took us a couple months of working with him. This is definitely not one of those instant fixes by any means, but it takes a little time to adapt. So his initial map also, this was it. I want you once again to take a look at where his threshold levels and his upper comfort levels were. So 97 on that first electrode for his thresholds and 142 for his upper comfort levels here. First thing we did, once again, we ran a few of his eCAPs, and then we performed eSRTs on him. So I want you to look where he's coming at here. He, beforehand, word recognition wise, he was coming in about 30 to 40% when we first got him. And then after reprogramming, this is what his map looked like. So you've noticed that his upper comfort levels have significantly increased. His eCAPs kind of alluded that we probably needed to boost them up a little at the higher, but that eSRT measure definitely gives us a great idea of where those measures should be set. And we lowered his threshold levels, if you noticed. So the reason that was done was over time, over the years, as technology and cochlear implants have progressed, a few years back, if you got somebody to a sound field threshold mark of about 30, 35, they were doing fantastic. That was great optimal performance. Now we're getting cochlear implant patients that have consistent sound field thresholds at 10, 15 decibels. So because of this, people's thresholds and softness levels are getting so good they can actually hear the inner workings of the processor actually happening. Adults have told me sometimes that it sounds like a whooshing sound, a machine type sound, staticky. I hear that one a lot. So if you're 6 years old and you have no way to explain staticky, you explain it the most common way that you can. And in this guy's case, it sounds like it's raining in my head. So one thing that you can do is lower the threshold levels a little bit in that patient, and it can resolve because it allows more of the environmental noise in, and it opens that dynamic range up a little bit more to allow some more of those sounds in to hide the fact that they're hearing those staticky sounds. If you're using an advanced bionics processor, you can also increase the dynamic or input dynamic range, or you can lower your thresholds. Either one of those will help reduce some of those staticky issues that some kids are experiencing. So putting it all together, sorry for the lecture, but I feel like you had to have some basis of background and information before you can actually put that into clinical practice. So I hope this was somewhat helpful for you. eCAPs are a great tool to use for neural integrity and also audibility, so you find out what somebody is actually hearing. But remember, it should not be used as a level to indicate where threshold is for your T levels in your mapping, or your C or upper comfort levels by any means. It should somewhere fall in between in that range. And likewise, your eSRT measures done with a tympanometer are used to find out where our upper comfort levels were. So that is a great tool for finding out if somebody can't tell you how loud things are, but remember, you have to have a normal tempo in order to do this. You run a decay at the 1,000 hertz, you present some tones through the implant software itself, and then you will start seeing those marks in your decay. Use this tool, use your eCAPs. There are so many more instances where we can increase our patient's outcome just by going a little bit more in depth, and it will benefit them so much in the long run. I cannot express enough how just using these measures would have solved a lot of patients' hearing issues, not only in school, but in work and just life in general. So please don't take shortcuts and use these objective measures. They're at your disposal, and eCAPs can just be done within the software itself. So please use them if any time possible, every time if you need to. Thanks for taking a listen to this talk. I hope it was helpful. This is my contact information at the University of Nebraska. That's my direct office number and my email address at the university. So if you have any questions at all, please let me know. I'm more than happy to help in any way. I had to throw this picture in here. This is by far my favorite patient on the planet. Yeah, thanks. Let me know if you have any questions by any means. And your CEU code for this session is K5JZB. Thanks again. I had to talk a little fast to get it all in a 20-minute span, but I hope it was helpful. Let me know if you need any help with anything. Thanks for listening.